Hello, my name is Dante Leonard, and I'll be covering septal defects. So what are septal defects? Septal defects are holes within the septum of the heart that would normally divide the right atrium from the left atrium, the right ventricle from the left ventricle, and then there on the right side of the screen you can see that I included a picture just to give a little refresher on anatomy and then that normal blood flow through the heart. So there are three types of septal defects: atrial septal defects, ventricular septal defects, and atrioventricular septal defects. So there on the left you can see the incidence. ASD 1 to 2 per every 1,000, VSD 4 per every 1,000, AVSD 1 per every 1,600. And then there on the right, morbidity and mortality. There is an increased mortality rate compared to the general population, even with repair, although those numbers aren't as high as you might think they would be, with 1 year surgical repair rates being as high as 95 to 99%, depending on what study you read. So who is at risk of developing these congenital heart defects? We don't always know a specific cause of a congenital heart defect. But some of the things we do know: maternal exposure to rubella, cocaine, marijuana, alcohol, metronidazole, ibuprofen, genetic inheritance, transcription errors in our DNA, other congenital heart defects being present, meaning that we can have ASD or VSD as a solo defect, but if you have one, you're more likely to have another. And then Down syndrome, AVSD is especially prevalent in Down syndrome children, and then Treacher-Collins syndrome and Turner syndrome. So I included this graphic because it helped me understand atrial septal defects. You can see that there's the septum secundum and the septum primum, and those are essentially the two flaps of heart muscle that close and adhere once the infant takes their first breaths. And when they do adhere, they close the foramen ovale. So I assumed, as I started studying, that that a patent foramen ovale would be an ASD, but it turns out that patent foramen ovale is actually a subclass of another ASD. So there are 4 different types of atrial septal defects: ostium secundum, sinus venous defect, ostium primum, and unroofed coronary sinus, with the unroofed coronary sinus being the least prevalent of the 4. All 4 are named based on their location within the upper chamber of the heart. We see atrial septum development in the 4th week of gestation. Normal shunting is left to right due to the higher pressure on the left side of the heart. When we see right to left sided shunting, that's referred to as Eisenmenger syndrome, and that's due to the left side of the heart failing because of the overcompensation. And then that leads to pulmonary hypertension and congestive heart failure. So we see VSD development when there's an abnormality or interruption on the DNA chain for ventricular formation, and similar to the ASD, it creates left-right shunting because of the higher pressure or gradient pressure on the left side of the heart. So there are four types of VSDs: perimembranous, infundibular, inlet or atrioventricular, and muscular. Again, just like the ASDs, dependent on where they're located within the ventricles. So when I think about atrioventricular septal defects, I think about the endocardial cushion. The endocardial cushion essentially makes up or is part of the mitral valve, the tricuspid valve, the atrial floor, and the ventricular ceiling, essentially. And when we get a defect in the endocardial cushion, that's when we see atrioventricular septal defects. And then just like our other defects, there are subsets to atrioventricular septal defects. So you can have a complete, a partial, or transitional. And then I included a graphic on the right side just to give you kind of a visual of what those might look like. So most of these patients will be asymptomatic because the defect will be small enough. If the defect is too large or large enough, then we'll hear a murmur around 2 to 8 weeks potentially. We can hear rails in the lungs because the left side of the heart is essentially beginning to fail, and because of the fluid overload. We'll see the patient fatigue easily during feedings, especially poor weight gain, tachypnic, tachycardic. We can see a precordial bulge or a palpable lift at the sternal burnal, or at the left sternal border. S1 will often be normal or split. S2 will have a wide fixed split specifically, and then S3, S4 gallop is present if the patient progresses to congestive heart failure. So echocardiograms are essentially the gold standard for pinpointing where the defect is. If we're able to hear a murmur or symptoms dictate us to send a patient for further testing, we can send our patients for ECGs. We can do chest X-rays within our location or within our office, and you may be able to see enlarged cardiac tissue. And then cardiac caths, they're actually rarely used for diagnostics, but they can be used for treatment. So for a lot of our asymptomatic ASD and VSD patients, what we see oftentimes is if the defect is small enough, the defect will close on its own by about the age of 4 years old, depending on what study you're reading. So we simply monitor those patients every 3 to 6 months during their first year of life, and then annually after that. Almost every patient that has atrioventricular septal defect ends up receiving surgery. We can treat them with digoxin, diuretics, ACE inhibitors, and beta blockers until they're old enough for surgery. We want to educate families on the signs of congestive heart failure, like tachypnea, tachycardia, wheezing, edema, poor weight gain, stuff like that. And then more treatment. We want to monitor nutrition and weight gain, so we may have to fortify the infant's food to 30 kcals as needed. We may also have to educate families on NG tube care because they may end up requiring an NG tube, and then closure of ASDs as possible with a cardiac cath. So those patients will require 6 months of post-op prophylactic treatment for endocarditis. So on the patient side, as that patient gets older, depending on the size and severity of their defect, we're more likely to have that patient report depression or decreased quality of life. On the family side, there's going to be a lot of fear when you get that diagnosis as a parent. There's a financial burden, of course, that unexpected financial burden, and then the medication and treatment compliance part of it as well. In the pediatric nurse practitioner role, we are there for assessment of defects, education on treatment, medication compliance, and then to also serve in a support as a support system, a patient advocate, or referral system wherever needed. So some of the resources I found: the American Heart Association, the Patient Access Network, and the Patient Advocate Foundation. Those last two have a lot of resources to help patients financially, specifically. And then here I've posted a few questions for you to answer. Thank you for listening to this presentation.